Well, thank you very much for that kind introduction. I'm really, really thrilled to be here today. I know you can all read the first slide and see what it's all about. But really, what I'm going to present to you today is what I believe are the workplace depression top 10 hints for what you all should be thinking about. It's really my attempt to address one of many mental health issues that you're going to face, whether it's you yourself personally, with someone you love, within your community, or within your workplace. So I'm going to take my time to work through this and start off by talking a little bit about how I ended up here at TELUS. If I can make my slides move forward, here we go. So I'm what's called a chief neuroscience officer. I was asked to come to join TELUS, as Sal mentioned, to help to ensure that all of the products and services we have in the mental health sphere are based in science, that they're accessible, and most importantly, that they're patient-centered. So before I was a psychiatrist, I was in medical school. And before that, I went to pharmacy school. So I have a long clinical experience. I've certainly learned a whole lot about business over the last year as well. But it's been wonderful to actually be able to make sure that all of the work that TELUS is doing on the mental health front is really steeped in the science underlying the approaches that we take, as well as making sure that patients are in the center of every decision. So we have a number of resources within TELUS that I'm involved with. One are with the TELUS Healthcare Centers. And in that, we have a brand new mental health center in Vancouver, and looking forward to having really these wonderful multidisciplinary mental health clinics across the country that are open for anyone, that are, again, multidisciplinary, meaning that we have psychologists, social workers, clinical counselors, psychiatrists, all kinds of different care providers, making sure that we're offering whatever the individual requires to overcome whatever challenge they're facing on the mental health front. We also have a huge reach from a virtual care perspective, and we have mental health offerings through those virtual care clinics as well. We have the Esprit app, which was designed actually with first responders, for first responders and frontline healthcare workers, to provide them with resources to manage their mental health. Stigma, of course, is an issue in society. It also lives in medicine, unfortunately, which makes it really tough sometimes for people to access care. And the people that are really struggling right now during this COVID crisis, the first responders and frontline healthcare workers, they're not immune to stigma. And in fact, even though they understand the ubiquitous nature of mental illness, how common it is, they still struggle to ask for help, maybe view it as a kind of weakness. Even their schedules can make it challenging to be able to access care. So that's what the Esprit app works to do. One of my big jobs is involved in education for confronting stigma, but also supporting our team members, our customers, and our communities. And it's the thing I like to do most. And as well, TELUS is walking the talk, I would say, making sure that our team members have access to mental health resources as well as a mental health account. So really very generous attempts to make sure that all of our team members have access to the care they require. So I'm going to walk you through my top 10 here. And my first one is that depression is very difficult to define. Now, this is my big book of psychiatric diagnosis. We use the DSM-5 in Canada, the US, in Europe. They tend to use the ICD-10, but it has all of the diagnosis that we rely on when we are trying to characterize someone's symptoms. Now, diagnosis isn't everything. And in fact, I believe it should be quite therapeutic. When I say to someone, I think this is what's going on, generally what I get is shoulders dropping and a sense of relief, because people feel very alone, very isolated when they're living with a mental illness. And for someone like me to listen with empathy and caring, and then say, I think I know what's going on, and I think I know what we can do to help you to turn this around, that's really helpful. The DSM diagnosis for major depression, there are 9 symptoms. You need to have 5 of the 9 symptoms for most days, nearly every day for 2 weeks, and a change in previous functioning. And actually, that's critical for every psychiatric diagnosis. You don't meet a diagnostic criteria without having functional change. in your usual roles. And that can be at work, but also at home as a parent or as a partner. Now, it's surprising to some people that in order to have a diagnosis of depression, you need to have one of two things, but you don't need to have both. You have to have a depressed mood, or you have to have what's called anhedonia, or a loss of interest or pleasure in things that you would normally enjoy. Now, people are surprised by that because they think, well, you can have depression without a depressed mood. And in fact, yes, sometimes when you ask people if they're depressed or if they're feeling depressed, they'll say, no, I don't feel anything. So for me, a more important indicator of depression is actually that anhedonia. Then there's a constellation of other symptoms. And when you take all the permutations and combinations together, there's more than 1,000 different ways that depression can present. So no wonder people struggle with what is depression, or how do I define depression, or how do I know I'm depressed? Because every person can look a little bit different. Just look at the fact that your appetite can actually increase or decrease. You can have hypersomnia where you want to sleep 24/7 and you still don't feel rested, or people have insomnia and they can't sleep at all. So it is challenging for people to accept a depression diagnosis, often because it doesn't look like what they thought depression was. Number 2, all mental illnesses have biopsychosocial origins. So people often ask, well, why did I get depressed? And there's no one risk factor for depression. There are many, and they fall into 3 different buckets. One is the biological. So that's things like your hormones, neurotransmitters, genetics. And that is a critical piece for some people. They have a more or less genetic depressive vulnerability. Our 2 most heritable psychiatric illnesses are actually ADHD and bipolar disorder. Depression can be heritable, but not as much so as those disorders. So the biological factors are the things you tend to think about, the brain chemicals and your genetics. The psychological factors are just important, if not more so. And those are things like your temperament, your coping strategies. What kind of coping skills do you have? Everyone sort of pops out of the womb more resilient or more vulnerable. We're all at a different place, but you can grow resiliency over time. People who have a lot of stress, a lot of trauma, especially in their early life, may be more psychologically vulnerable. And then finally, the social. If you're away serving overseas in the military, and you come home and your wife's having an affair and your kid's being dragged off to jail and your house is being foreclosed on, you can see that that's a recipe for disaster. Those social factors are really very critical. And one of the greatest supports, or the one of the greatest protectors of our mental health, is actually social support. So if you're living in an environment with very little social support, and especially right now, a lot of us are facing isolation and loneliness, that is a powerful predictor of depression. Number 3, men and women are different. And I don't think I need to say that out loud. Most of us know that. Women are twice as likely to develop depression and many other mental illnesses. So schizophrenia risk is 1-to-1. Men and women are about equal. Bipolar 1-to-1. But many, many other illnesses, women are twice as likely to develop those disorders. Why is that? Well, I blame estrogen. Now, estrogen changes. So when you go into puberty as a woman, then you have a high level of estrogen, and that stays up there pretty much until you hit the perimenopausal period, where it starts to become very uneven, up and down all the time. And when you're menopausal, whenever that happens for you, it's back in your boots again. That is strangely also very well aligned with what happens when you sleep through the night. Most people find they sleep okay, and then they get into the perimenopausal and menopausal period, and they don't sleep as well. It also is tracked very neatly towards the likelihood of being hired as a Hollywood love interest. As a matter of fact, I just read an article maybe a week ago about a woman who was talking about, she was an actress, and she said the day after she turned 40, her agent asked her to read for a grandmother role. So our bodies do change with estrogen as well. Estrogen changes, but what happens is that when you go into the perimenopausal and menopausal period, your estrogen levels do drop, but your brain has been bathed in estrogen over all of those years. So our estrogenized brain still presents a risk. So the depression risk is twice as likely throughout our life and includes in those perimenopausal and postmenopausal periods. Our bodies are also very different. So how we manage drugs, what happens as things move through our bodies is different. So men and women in every respect are different. Number 4, depression is an inflammatory illness. Now, many people don't know about this, but let me tell you, the science is just very, very clear. Everything that I say is supported with a great deal of research over many, many years. So when you're living in a chronically high stress kind of environment, and many of you will find that this last year has been really exposing you to the worst kind of stress for your brain, which is chronic and unpredictable stress. Some of us are more resilient, some of us are more vulnerable. So the more vulnerable among us, those who've had a mental illness before or are living in a very stressful situation, that makes us more vulnerable to developing a mental illness as a result of that stress. But when you're living in a chronically high stress environment, that has an impact on the level of cortisol. Now, cortisol is the most important hormone that reacts and helps us to manage acute and chronic stress. So when you're in a stressful event, there's an increase in cortisol, and it helps to protect your brain and body and bring you back to homeostasis quickly. But if you're in chronic stress, your hypothalamic pituitary axis that drives that cortisol level is in overdrive, and your cortisol level is too high for too long. It's very similar actually to type 2 diabetes. We don't give insulin to people who have type 2 diabetes because their insulin level is too high, right? What we do is we try to make the cells more responsive to insulin because they become insulin resistant. When you have chronic depression, chronic anxiety, you have this high level of cortisol, it keeps going, you're running on this high level. And what happens is your cells become resistant to that cortisol and in fact get damaged. The damaged cells include our glial cells. These are our brain support cells. They're critically important for everything we do. I've just named 2. The astrocytes, those are the ones that help to fuel neurons, the primary brain cells. The microglia are our brain vacuum cleaners. There's also oligodendrocytes. And what they do is they form the myelin sheaths that help to send those electrical messages around your brain. And that chronically high cortisol starts this inflammatory cascade that actually damages those glial cells. So they put down the vacuums, they stop cleaning up, they stop taking care of neurons. And what happens? We end up damaging and killing neurons. And how do I know that? Because we can actually see shrinkage. We can see that there is a decrease in what's called dendritic arborization, or the arms that come off those neurons that help to make those healthy connections. So they shrink and neurons shrink and actually die. And there's a particular area of your brain called the hippocampus that shrinks, that loses volume in chronic depression. Now, there's very good news, however, which is, first of all, many of you may not realize that you grow new brain cells every day. It's called neurogenesis. And in order to recover for depression, you actually have to grow new brain cells. You need to have neurogenesis. If you block neurogenesis, antidepressants don't work. That's how they work. So we know that growing new brain cells is an important part of recovery from depression, but it's also part of just being alive. Unfortunately, like most things, peaks around 30 and goes downhill afterwards, but it still continues through your life, this growing of new brain cells. And here's an actual picture of new brain cells growing in the dentate gyrus of the hippocampus. They join the hippocampal circuitry and work just like the old brain cells. What happens is with chronic depression and anxiety, you lose brain volume, you lose neurons, you lose their connections to other neurons. But as you recover from depression, you grow new brain cells and you increase what's called neuroplasticity, which is the wiring of your brain, those critical connections. That's all part of recovery. Number 5, the mind and the body are connected. This is why I needed to go to medical school to be a psychiatrist, is I need to know what's going on all over your body, not just in your brain. And we know that mental illness are connected to physical illness, obesity, diabetes, heart disease, all inflammatory illnesses, pain, your experience of pain, abdominal symptoms, which is why we have so much problem with irritable bowel kind of symptoms that are associated often with your level of anxiety or with depression. The reverse is also true. If you have any mental illness, including ADHD, you have an increased risk of a mental. If you have a mental illness, you have an increased risk of physical illnesses like obesity, like diabetes, like heart disease. Number 6. Depression can become a chronic disorder and should be treated as such. So we have chronic disease management within our virtual care system, and I'm working towards making sure that mental illnesses are included in that group, because we tend to think about chronic disease management as managing diabetes or managing congestive heart failure, for instance. But mental illnesses are chronic diseases, and depression and anxiety are as well because they're neuroprogressive. That means that they worsen over time. So the longer duration of an episode, the more episodes you have, the more likely you are to actually have changes in the way your brain is structured, as I showed you earlier with that shrunken hippocampus, and also the way your brain functions. So those functional and structural changes have an impact on your brain over time, leading to greater treatment resistance. So less likely you are that you're going to respond to treatments. It's going to lead to greater cognitive impairment and greater functional impairment. You're less likely to be able to assume your usual roles, be an effective parent, be an effective worker in whatever role that you have. So we have to treat depression with a sense of urgency, and we haven't for a long time. We haven't seen that it is necessary to get in as quickly as we can. It doesn't mean everyone needs medication. I'm going to talk a lot about medication. We need to actually intervene much earlier and on a preventive level so that we prevent people from ending up in a functional impairment or crisis level where we need to actually bring out the big guns. If we don't treat early and completely, if we don't treat every symptom, that increases the likelihood of long-term harm. And in fact, residual symptoms of depression. So someone will say, well, I'm not depressed anymore. I don't feel sad anymore. And I want to go to my kid's soccer game, but I still can't get out the door. I'm tired. I'm still not sleeping well. Those residual symptoms are the greatest predictor that someone's going to get depressed again. So we need to treat every symptom. And that's why I write here fully is important. Now we have a window of opportunity in the first 6 months after someone is ill. That is our greatest chance of getting them back to full functional recovery. They have a full remission of symptoms and they're back to their usual role. If you don't get going in those first 2 months, you greatly increase the risk that that person is going to have chronic, permanent disability. Even by a year, the likelihood of getting someone perfectly well after they've had depression symptoms for a full year is at less than 10%. And if you end up with someone who has treatment-resistant depression, meaning we've tried multiple medications and they're not working, you have less than 20% chance of getting a short-term remission of symptoms, and you have less than 10% likelihood that they're going to be free from depression symptoms after 2 years of treatment. Those are abysmal numbers, and it highlights the importance of early and complete treatment as quickly as we can for that patient. Number 7, personalized treatment, choosing the right treatment for the right person at the right time. So as I mentioned earlier, we have I think everything is on a spectrum, don't you? It's not just mental illness, but mental illness is absolutely on a spectrum. And even within different mental illnesses, there is a spectrum. But in general, I tend to think about the spectrum of mental illness as being from healthy to stressed to functionally impaired and into crisis. And what that looks like is if you're healthy, you've got those solid support systems, you've got healthy personal and work relationships, you're feeling in control. I've written this mostly from the perspective of at work. If you're stressed out, you're having some sleep problems, maybe reduced confidence, you're having some tension with team members, maybe you're starting to feel burned out, some physical symptoms, then on to functional impairment, when perhaps that's when self-medication is happening with alcohol, with cannabis. Feeling irritable, isolated, breakdown in relationships, and feeling cognitively impaired. Your brain is there. You're at work, but your brain isn't. You don't feel like it's working for you. And then on to crisis, where really you shouldn't be at work. You have very significant symptoms. And you can see that the impact on functioning starts to become impaired. You're still functioning when you're stressed out, and it just grows from there. And when you're in that crisis realm, you really are struggling to be at work at all. And of course, it's potentially life-threatening from a suicide perspective. And of course, as we push people over towards, as people move over towards the right, it becomes more and more expensive for healthcare systems. So our job should be to constantly be pushing people back towards the left and trying to do all we can in the healthy realm, which may surprise you that we can intervene in the healthy realm. But here we go. Maybe teaching people about the power of exercise to grow new brain cells, that it actually is a treatment for mild depression. And for my patients that have really severe depression that include exercise in their treatment regimen, it can, to me, it's a drug, and it can prevent them from getting sick again. Maybe you're feeling a little stuck at work, even though you're functioning well, and you would benefit from a personal coach. I'll just touch on the gut biome, which is a huge area of research, how your gut and your brain are connected. And so how healthy eating can actually help to keep you well. When you get into the stressed realm, well, all the stuff that you're doing when you're healthy, plus maybe there's a value to doing some psychotherapy, to getting connected with a counselor. Maybe your stress is related to finances, and many EAP programs offer financial support, but people don't necessarily access them because they don't know that they're there, or they don't trust them. So there's a lot of education that we need to do around how confidential that kind of stuff is. Sleeping tools, because sleep tends to be a really early harbinger of things not going in the right direction. Once you get into functional impairment, bringing in that family practitioner, nurse practitioner, along with some talk therapy benefit, all the time trying to encourage all of the healthy aspects. And then once you're into crisis, well, that's when you need to have someone like me involved, a family practitioner who's really skilled, disability management programs. Number 8, medication choice must be individualized to meet every person's needs. So it's sad that I have to really address this, but there's still a lot of people that don't believe, because they don't know the science, that antidepressants absolutely work. They do, but they don't work for mild or moderate depression because they're not needed for mild depression. But if you have a moderately severe or severe depression or anxiety, they can be extremely effective. The problem is that every antidepressant doesn't work for every person. So our job is to find the right medication for the right person. Now, I will make the point that sometimes depression can look like it's unipolar depression, but it's actually bipolar depression, and antidepressants do not work in the same way for bipolar depression. Or maybe a person is so ill that they require another kind of treatment like ECT. We have now a nasal spray called esketamine. There are other options that are available, but there is no doubt, with an abundance of data, antidepressants work on a population level. They just don't work for every person, which is why individualization is so important. So are antidepressants all the same? Well, no, each one is unique. And we tend to think about medications in buckets, or at least in my little world, we do SSRIs, SNRIs. You've probably heard those terms before. But even in each bucket, every SSRI is a unique chemical entity. So I can have a patient fail one, that doesn't work for them. So they don't do well with Cipralex, they don't do well with Prozac, but they do beautifully on Zoloft. Each one is a unique chemical entity. Now, because I'm working with a sense of urgency and a need to get that patient better as quickly as I can, if they're not successful on one SSRI, I'm likely to change class and go to an SNRI or another class of medication. And we have a whole lot to choose from. You don't need to worry too much about this, except I'm going to show you the first line, second line, and third line recommendations from, these are Canadian guidelines from 2016. I hope they update them soon. But if you look at all of the recommended medications, antidepressant medications, there's 25 different antidepressants. Now, about 20 of them are available in Canada, 5 of them that you can only get in the US or in Europe. We have a lot of choices. Do we need all these choices? And the answer from me is absolutely yes, because of the point I made earlier, which is we got a whole lot of antidepressants, but they don't work for everyone. Now, one of the greatest challenges I have, and why I became quite a burned out psychiatrist, was because I didn't have access to what I thought were the best treatments for each of my patients. Most of my patients came from a very low income, and so they relied on provincial formularies. So as I've said again and again, and I will continue to mention, that we have to individualize treatment for each person, because each chemical entity has a unique receptor profile and every brain is unique. This is a huge barrier to access to what I think is the right kind of mental health care, is that we don't have access to all treatments, especially innovative treatments and newer treatments. So the newer antidepressants we have 2 or 3 over the last 10 years or so that have come down the line. They're not, when you look at the whole population, more effective than other antidepressants. But what the newer medications do bring is usually better tolerability, that there's less sexual dysfunction. I'll talk more about side effects, less weight gain. We have a brand new medication. It's the first new mechanism of action for an antidepressant in 30 years, which is really a sad indictment of the research and development that's going on in mental health because we can't get treatments covered. It's called esketamine. The brand name is Spravato, which is like ECT, electroconvulsive therapy, but through a nasal spray. And so it can be done in a family practitioner's office or in my office. But access to that treatment is very difficult because of cost. We have restrictive formularies in every province, but also clinicians who are overburdened with a very high burnout rate. They're often unwilling to take the time to fill out the forms. They're not aware that some insurers may have some special requirements. And I will add that a lot of people that are providing guidance for patients don't have the clinical experience or knowledge to be able to make the right decision. We have family practitioners doing probably at least 80% of the psychiatry in this country, and many are awesome, but many are not and not super interested. And so we need a lot more education to help to bring up everyone's game on the mental health front. Number 9. No drug will work if it's not taken. And this is further to my point about the problem with some antidepressants, and especially some of the older antidepressants. First of all, people are given a prescription, and as they walk out the door, it may go in the purse and never be filled. But of the people that fill it, within the first 30 days, about 40% will discontinue the medication. Within the first 3 months, we're getting close to 75% of people stop taking their medication. And people do not take their medication regularly. So about 40% of days, people don't take their medication. I've stopped entirely asking people, are you taking your medication? I ask them, how often are you taking your medication? And that's because people like us, we're trying hard. They know they don't want to disappoint. But this way, I understand why the treatment might not be working, and we can address why and understand, is this not the right treatment for you? Why aren't you taking your medication every day? Maybe because it upsets my stomach, but I didn't want to bother you about it. Or I have another problem and I didn't want to mention it. And it's really difficult in a short appointment time to go through every potential reason. So understanding why someone's not taking the medication can really help to address what the issue is and maybe find a new path ahead. So I base my choices first and foremost, as I started this whole conversation with, which is the patient being in the center of the decision. What is their need? What about the severity of their illness? How quickly do I have to act? What do I got to get on board as quickly as possible to help that patient to stay alive first and foremost, and then get back to their usual roles? Maybe they have other health or medical conditions, other mental health conditions that I need to address, comorbidities that are going on. They're struggling with substance use. Maybe they have depression plus they have ADHD. What kind of symptoms they're facing can determine what choice I make, as well as what's worked before or what they have a good feel about. You know, my granny was on this and she loved it. Well, that's a good feeling that I might want to jump on and say, if your granny was happy, why don't we try it for you? The game changers are the side effects. And for some people, that is just like, I will not take that medication if it causes me sexual dysfunction or causes me weight gain. And then, of course, the cost and whether it's covered within the provincial formulary or their own formulary. So I've talked a lot about medication here, but I also want to make the point that psychotherapy has a great deal of value, a huge amount of empirical evidence, and it needs, of course, to be personalized. And there's lots of different modalities by which people can experience a really important psychotherapeutic relationship. You can have one-on-one. Group therapy is actually underrated and highly valuable. It's meant to really set up a family dynamic. And so there should be some heterogeneity in a group, but we know that group therapy can be very effective. Many of my patients would say, well, I don't want other people to know. Well, everyone else in the group also doesn't want other people to know. So there's a lot of education that has to go on in encouraging someone to consider a group therapy session, particularly because it's less expensive. You can also have one-on-one therapy virtually and group therapy virtually. And then there's internet-based or digital CBT with or without skilled guidance. So you can have someone who is providing asynchronous support as you're going through CBT, but there's also evidence about the value of using books or internet-based CBT, but you have to be motivated. Your brain has to work to benefit from psychotherapy, from formal psychotherapy. Supportive psychotherapy is always helpful in the process of letting someone know I'm here and I care, and let's think about ways that you can improve the quality of your life. But when you're talking about high quality CBT, formal psychotherapy, you have to be able to learn to be able to benefit. So if you're unable to read a newspaper article, get to the end and can't remember what's at the beginning, you may not be well enough to engage in CBT, and you lose faith in the process. You lose faith in the treatment when it's just because you're not quite well enough. And so sometimes medication is necessary to get someone to the point where they really benefit from CBT. There's a whole bunch of other therapies. I mentioned exercise grows brain cells, mild to moderate intensity. It's a really good news story. 30 minutes a day, no Lululemon required. I'm not looking for a 4-minute mile. Just getting your heart rate up for 30 minutes a day is enough to grow new brain cells and can be a treatment or a preventive measure for depression. Sleep, underrated, the best thing that happens in my day. And it's essential for you to be able to learn, for kids to learn. And that's our kids don't get enough sleep, which is part of the reason they're suffering from anxiety. Light therapy has evidence not just for seasonal depression or a seasonal affective disorder, but also for regular depression. And you can't tell me that you don't feel better with the sun outside your window as opposed to being gloomy. And we get really socked in here in Vancouver, and it makes you realize what seasonal affective disorder is all about. As I mentioned, social support, a critical factor in preventing mental illness and helping people to recover from mental illness. And that includes a supportive work environment, mindfulness, omega-3, faith. If you're a believer, there's evidence supporting the value of faith, a healthy gut biome. As I mentioned, that if we have the right bacteria in our gut, there is tons of evidence showing its connection with brain health and why it's critical that we maintain a Mediterranean diet. Some science showing it having the same level of prevention as exercise when you're trying to recover from depression or dealing with a mild or moderate depression. Number 10, medicine has changed for sure, the field of medicine, but not enough. So we got to capitalize on some key trends. We've been through this pandemic, and there's some really, out of horrible things, good things can come. I learned this from treating PTSD over a very long time. Out of the worst things, some good things can come. But we need to hold on to those new learnings and continue to develop. It's essential that every healthcare provider and every organization realizes that patients own their data, and they should also own their healthcare decisions. I am merely a well-informed navigator. My patient drives their own ship, and they need to be able to make their own decisions. We also have a problem with doctors and that they don't want to give up their life to medicine anymore. The sort of old-time country doc who doesn't raise his own kids, his wife is at home doing it, and he's out taking care of everyone else. Well, people don't want to do that anymore. We know that millennials value experiences over money. And so we have to find new ways to amplify access to care from specialized healthcare, and psychiatry is a particularly difficult resource. How do I amplify me to be able to care for many more people, because we can't offer the access that people need. Virtual care is absolutely critical for the survival of the healthcare system. And I believe it will improve health outcomes because it really goes to where patients are. I see people in police squad cars. They're the police officer. So the officer pulls over and we have our appointment. I see people in Starbucks. I see people where they are. And I will admit, when I started doing virtual care about 3 years ago, I was really anxious about it. But my goodness, my patients love it. the time savings, not having to get childcare, not having to put money in the meter, not having to drive for hours. It's been remarkable. And as long as I can see the person face to face, which I can through virtual care, I think we're falling a little bit too much on the phone. It's critical that we be able to see each other. It democratizes medicine, and I think it's really going to change the way that we practice in the long term. I hear a lot about, young people don't care about continuity of care. That's because they don't know about continuity of care because they've never had their own family doctor forever. And that is really valuable, that whoever you're seeing, they know about you, they know their history. Even, I went to the emergency department and they told me some stuff, but I don't remember what they said. And your doctor never gets that information. So we have to, whatever we do within TELUS, whatever I do with my day-to-day life, it needs to consider how can I get that message between care providers as well. That way we provide the best quality care. These are some of the questions that I have to consider when I'm reviewing a patient or reviewing something within TELUS, considering new opportunities in the mental health sphere. Does it meet a need? Is it based in evidence? Will it work? Can we measure it? Because we know algorithm-based care and measurement-based care improve patient outcomes. Is it accessible? Can anyone use it? Is it intuitive? Do people understand it? Is it safe? Is it accessible? Will physicians actually recommend it or use it? And does it align with our very high quality standards and expectations of anything that we do within TELUS? So I'm going to leave you with this. And I have a little plaque in my office that I thought actually was what was said by Winston Churchill during one of his speeches: never, never, never give up. So it's kind of like my little motto with my patients. He didn't say that, in fact, though. What he said was this: success is the ability to go from failure to failure without losing your enthusiasm. So there's always a path ahead, no matter how severe your mental illness is. And I see people who are very, very ill, but there is always a path ahead. If a patient is in my office, that is because they have hope. That is because they believe that there's a path ahead. And that is my role to empathically, but with science, drive and help them to figure out what the next steps are in their path. So here's to success. Thank you very much for your kind attention. Oh, I can't hear anything.
It's the virtual world.
There you go.
Yes, I've unmuted myself. Thank you very much. This is very insightful, and I'm sure everyone finds it very interesting. Remember, the Q&A button's on the right-hand side. If you have any questions for Diane, please put them through. We are at our Q&A session, so I do have a question for you that we just received. So if you could, let's see, I will read it.
I can't see it.
But I can, so I will read it.
Okay, thank you. That would make it easier.
Yes. Over the pandemic, how often are you recommending pharmacogenetic testing for patients? Do you find it helpful in the treatment process?
Okay, well, I wouldn't say that this is a pandemic specific question, but I would say that pharmacogenetics is a really interesting question because it's a growing area of interest. I believe in the value of pharmacogenetics, but it is a point of debate, particularly in psychiatry. So some of the big organizations, the American Psychiatric Association, for instance, are not recommending routine pharmacogenetics. But also in the US, some of the big insurers, and we know that they're really focused on making money, are actually very supportive of pharmacogenetics, even after the first failed antidepressant. So that suggests that their money is on the fact that anything that they can do to help to hone in on a better treatment earlier really is worth the money. So they're paying for it because of that. Now, most of my colleagues are not doing this regularly, but I would say that it has certainly been a value in my own clinical practice if I've tried an antidepressant or two and I'm clear on the diagnosis, because we always have to go back and make sure we're dealing with the right diagnosis. But if I'm very sure I'm dealing with bipolar or depression and that we're failing to find a medication that works, pharmacogenetics can really be invaluable. We just haven't had the pickup that I think ultimately will have within the coming couple of years, honestly.
Thank you, Diane. I'll pose a question to you, and maybe the audience is interested in this one. You talked about patients having access to more than 25 different medications for depressions alone. Why do we need new medications if all of these work?
Well, hopefully I have addressed that during the talk, but just to remind people that every brain is unique, every individual is unique. And so while we have in Canada 19 or 20 different antidepressants, all come with a unique chemical structure that may or may not work with each individual brain, all come with some risks, some side effects, and some people will not find those to be accessible or acceptable to them. Some come with greater risk in overdose, and that's why a large number of those medications have really been pushed to the wayside, as we tend to use the SSRIs or SNRIs, the newer groups of medications, more often. Although I will point out that some of those medications, most of the newer ones, have very low risk in suicide, but one or two of them still have that risk. So it's related to side effects and individuality of each person's brain, why we need to have lots of different options available, because we need to find something that works for that patient.
Thank you, Diane. Are you up for one more?
Of course.
Okay. This came in. You referenced the success of someone who suffers from depression and how quickly they get treatment. The 10 to 20% figure were frightening. People often don't seek treatment right away. Do you mean once they have reached the crisis stage?
Right. So if you're thinking about someone who's got moderately severe or severe depression, if they are unable to respond to a treatment, we can't find the right treatment for them, and they continue to have symptoms for a year, those are the kind of numbers we're looking at. The likelihood of someone fully recovering after having moderately severe depression for a year is less than 10%. So you're right. The statistics are terrible. And I got to say, as a psychiatrist, I never see anyone with a lovely garden variety depression that gets better when I give them the first medication. Thankfully, we've got lots of fantastic family doctors that are able to manage that depression very quickly with that patient and get them well again. But the big challenge is not having access, not facing stigma, so not going and asking for help, not being heard, not being offered other alternatives if the first medication doesn't work. So we're creating a lot of problem for people by not treating with a sense of urgency, treating fully, managing all those residual symptoms. I often ask family doctors when I'm giving a talk, why I talk about residual symptoms and the fact that, you remember, those are the things that, I'm not depressed anymore. I want to go to my kid's soccer game, but I'm still tired. I'm still fatigued. I have these leftover symptoms. And I ask them, why don't you treat every symptom of depression? Why do you leave those residual symptoms behind? And then I answer very quickly. And I know that you try to, but you also have a patient who may be saying, my husband doesn't even believe in depression, and now you want me to be on 2 medications. Or my last drug was only 1 milligram and this one's 100 milligrams. And so they're listening to negative influences externally, and also they're driven by Dr. Google. And so they're getting inaccurate information. So it's not just all on the shoulders of the family practitioner, it's also patient education and trying to get them engaged in the process, because they get a lot of negative influences in their life, and they're facing a lot of stigma when they try to come forward.
Thanks, Diane. I'll take advantage and ask one more,
Sure.
if you're up for it. Through this pandemic, have we as a society had the right balance between physical health and mental health?
That is such a great question. So I mentioned that the kind of stress that we're under over the last year, and I don't know about everyone out there, but we're all sort of running on adrenaline It seemed like the first part of this, we knew it was going to be not just a marathon, but an ultra marathon. But I think most of us are running on fumes right now. And this is the worst kind of stress to be under. And remember, in the beginning, we didn't even know where this came from. We still don't fully know how we can catch it. Everyone's wiping down everything. The kind of stress we were under was this chronic, unpredictable stress that makes us all very vulnerable. I call it the COVID-19 trifecta that we're all facing. We all have some degree of health anxiety, whether it's we're worried about our own health or the people we love or our community. We're under financial stress, whether it's maybe it's not your own job because you're here, you may already have a job, but maybe it's your loved one who's lost their job, or you're coming up to retirement, you're worried about your RSPs, you're worried about the global economy. And then the third part of that trifecta is the impact of isolation, of loneliness, of quarantine. And that has led to what I'm concerned about, which is a mental illness tsunami that's coming our way. And so we have to keep people physically well, but at the same time, we're not able to respond adequately. We weren't even before able to respond adequately to the mental health needs of our community. And I think it's even worse now. And we have to think about that. You know, as we close everything down, our financial impacts on our mental health are huge. So are we doing a good job? I don't think anyone's doing a good job at anything. We're learning as we're going, but I hope to heaven that we're all writing all this down, because there's going to be another pandemic and we need to prepare the next time. That was kind of a bummer way to stop, Sal. You got to ask another question. That wasn't a happy ending. The next pandemic.
Well, you know, I do like this question because I think it's important. Are the younger generation in general more open to admitting they do not feel well compared to baby boomers or older generations?
I think so. I think they're going to change the way that mental health, I hope that I'm part of changing the way mental health care is delivered. I think they're going to change the way that we think of mental health, that we talk about it. And, you know, I'm not sure because of some of the things that they're facing around social media, having a phone that they seem to sleep with, which is really bad for you when you don't sleep enough. So they're not getting enough sleep. They have high levels of anxiety. They're really worrisome what's happening with suicide rates. So as a group, they're actually very concerning and quite vulnerable. But at the same time, I'm happy to say that they're more apt to talk about it. They're more apt to reach out. And so, you know, with all things, there's the yin and the yang. They're at risk, but they're more likely to be okay to talk about it, share with their friends, and access help.
That's great. Well, thank you, Diane, for this insightful session and answering all the questions. There's actually a lot of questions, so we'll pull them together and send them out to everyone. But we've come to the end of the session, so thank you very much.
My pleasure. Thanks, everyone. Be safe.
Thank you.